next with neurological specific items related to COVID. So I will just take a second to give a little overview of what's to come. And again, this applies to the rest of the participants as well. We welcome you to join us for the remaining session over the next 2 hours from 9 to 11. And just some housekeeping again, we will take a little break, kind of a log-off break. Of course, you're welcome to do this, but at 9:30, we will take a few minutes of break as well. And just to give you a little overview of what's to come. So Dr. Khosravani is a neurologist at Sunnybrook Hospital. He's a stroke neurologist, and he's also an expert in quality improvement. So we're very happy to have him here, and I'd like to welcome him to share his insights on protected code stroke and neurovascular issues. We're aiming for 15 minutes, and then in order to give plenty of time again for questions in the same format. So welcome, Houman.
Thank you very much. Thank you very much, Hans. It's a great privilege to be speaking for everybody. Thank you for inviting me. I'm just going to share my screen. I just wanted to also thank all of the residents who are working with us, the front lines, and continuing to be so considerate and compassionate. And of course, all of the staff that are continuing to care for their patients, both virtually and also in the hospital. I'm just going to briefly dovetail to Dr. Romero's wonderful talk, and thank you for that, with regards to just some of the data from Ontario and what's happening right now, and then talk to you about the protected code stroke, which we developed right here in Toronto for the world to use, and then some aspects about crisis resource management in regards to a stroke code, which is essentially a brain resuscitation, if you will, acutely, and some comments from the audience as well about stroke and how it remains an emergency and why we're not seeing what we should be seeing potentially. So these are from yesterday. You can see the total number of cases in Canada, about 43,000. You can see the total number of deaths, about 2,200, and you can see that we have there are many curves being thrown at us, right? There are many curves, and so one of them that has flattened is this business of incident cases, and this just shows us that on a daily basis the number of daily reported cases has stabilized, and the orange line here is Ontario. And so you can see that that has been a positive thing through all of the public health measures. Despite that, though, people are still obviously affected and dying. Very similar to what Dr. Romero showed, these are our curves. These are all courtesy of Jennifer Kwan, who's actually one of our collaborators now. She's part of the flatteningmycurve.ca group. And here you can see the number of patients in ICU, again, ventilated and non-ventilated, again, somewhat stabilizing. And that, again, speaks to the fact that when patients do get into the intensive care unit setting, they are there for some time with essentially an ARDS or atypical versions of ARDS if they're ventilated. The deaths by each of the provinces in Canada continue to rise, though, and there is, again, some flattening of that curve, but it is still important to say that even though it is flat, that there are people obviously dying every day. And you can see kind of what that number looks like. And that's another important thing to keep in mind. So I'm only mentioning this because all of us as physicians and other health professionals have a role in continuing to keep up the pressure with members of the public, even when things are relaxed, to still continue with some of those social distancing or physical distancing and potentially masks in public as well. So Ontario has been kind of towards the top of the pack. You can see that our sister province, Quebec, has had the brunt of the cases, 21,000 compared to 13. They've had more deaths as well. But you can see that they have tested more people as well. That's an important point, as Dr. Romero was also alluding to. Our testing in Ontario has continued to be a challenge compared to, for example, Alberta, that had 3,000 cases reported with 319 deaths, with this many tests for 1,000 members of the population, 100,000. And so this is what our curves look like as of yesterday. So there's a lot of curves on this plot as well, but I want to show you what the red line shows us our tests per day. But you can see that the sort of the backlog curve, the green, the tests under investigations. In fact, we had a bit of a backlog and we resolved that, and now we're having continue to have a bit of a backlog in testing. And that's very important, again, when we try to contextualize what we're seeing in the hospital and what we are not seeing. One of the things that one of the questions from the audience alluded to, which is very concerning, is that when you look at the total number of patients and people that have passed away from this, and you look at what percentage of them come from long-term care homes, that is a very, very striking number. 78% have died. And what is more striking is perhaps this pie chart, again from my colleague Jennifer Kwan, that shows that nursing home patients or long-term care residents comprise 17% of the cases, yet they account for greater than 70% of those that are dying. And of course, this is important for us in stroke because even prior to the pandemic, we would receive patients from nursing homes and long-term care centers with stroke and other neurological ailments. It just shows you that if those two things are put together, it is unfortunately a very deadly combination. So I think, I think myself and all the other speakers, I think all of us are, all clinicians remain quite humble in the face of this virus. It would be disingenuous to say that we fully understand any of it. It is almost a full-time job to keep up to date with all of the knowledge that's coming out. But it is very important to say, and this is why Canada, as of yesterday, announced that it's going to put together a national task force. Because this virus is new. We've only had a few months of experience. It is new to humans. And we've had challenges with testing capability and also testing operator characteristics, the sensitivity and the specificity. We know already, for example, patients testing negative sometimes with nasopharyngeal swabs and then ending up in the intensive care unit only to have their endotracheal aspirates be positive. This doesn't appear to be as deadly as SARS-1, but it is infectious, and it is probably very infectious because of what we talked about, which is the asymptomatic spread. The knowledge about immunobiology is very key to our future success. What is a good titer? What does it even mean? And could there be recurrence and so on? Most of the infectious disease experts suggest that if a person does develop the disease and then clears it, they will have immunity for the current situation, the current pandemic, and perhaps not a second wave or so on, but that's what's understood. I do want to just take a few seconds to say there have been many sort of small polymorphisms of the virus, but there are two large so-called haplotypes. But if you think that the virus is exactly the same between all of the different places, it is not. I also wanted to put out a fun fact, which is this virus is about 29,000 base pairs, and our genome is about 6 billion base pairs. Just to sort of think about that. That's fantastic. COVID transmission appears to be asymptomatic, which is important when you think about patients coming in with neurologic illness. When we put out our protected code stroke, we surmise that patients could present with pure neurology. And again, in the context of those that may be completely asymptomatic, in the current state, as Dr. Montalban also stated, we're not testing everybody. We're not testing every single inpatient. So when you have an asymptomatic rate of about 30 to 40%, and there are now case reports emerging, it is quite possible for patients to present with pure neurology without other symptoms. GI symptoms have been described. Other non-respiratory symptoms or extra-respiratory symptoms have also been described. Incubation period is probably closer to 5 days, and symptoms develop by day 11 for sure, and most people are asymptomatic by the 2-week mark, are symptomatic by the 2-week mark, which is why that's suggested. The mortality rate varies from a population perspective, but the ICU admission rate has also varied. Italy had rates of up to about 16% in Lombardy. New York just published their data in the New England Journal, about 14% of patients, with mortality rate of those ventilated 88%. And I'm sure one of my colleagues, Dr. Singh, who's going to give a talk later, is going to comment about some of the challenges about the type of ARDS that these patients have and the challenges my intensive care colleagues have faced in trying to manage these patients, and the pros and cons of how we manage them may also contribute to this. 2 days ago, all of the heart and stroke societies in the United States put out a statement, again talking to the point of please come to hospital, and I encourage you to please tell your patients to still maintain that the hospital is a safe environment and that they should call 911 and come in if they're having stroke or stroke-like symptoms. We are still continuing to see severe devastating stroke. What we're not seeing are some of those minor strokes coming in, and so we do worry about that for sure. There are reports that this virus does cause a prothrombotic state. There is sufficient smoke to say that there is microvascular thrombosis caused by this condition, and that it may play a part into how these patients present with severe hypoxia, with relatively normal lung compliance, and initially just a little bit of maybe dyspnea, if in fact not much initially for very young normal people. And one of the hypotheses is microthrombi. There have been reports of increased rates of stroke in young people. There was a news media description of this for a potential pending paper in the New England, so I don't want to say this is fact, but this did emerge yesterday, that they talked about seeing a bit more stroke in younger people. It's a few cases, but quite odd, and this comes out of New York. And again, young patients with not a lot of comorbidity, some with minimal symptoms presenting with stroke as their presentation, which is why we wanted to make something called a protected code stroke to streamline what happens when a patient comes in as a code stroke, and patients delaying their presentation. So a code stroke should really not be taken minimally, even at the best of times, right? So a code stroke really implies what we say in our group as a sense of nuanced and measured urgency, and a sense of vigilance to be able to in an expeditious way, assess the patient, including exam imaging, and make a treatment decision. And so that, I can't emphasize how important the word code in a medical emergency is. And so what we try to do is essentially modify that, or just augment it, to the protected designation. And this protected designation is not new from other colleagues in other resuscitation fields. And so, for example, there is definitely a code blue or even protected code white now. And all it means is that we're going to put into place some very specific measures to keep the patient and the team and environmental exposure minimum, and to keep the other members of the team safe, especially when I sort of made a case for you now that patients can present asymptomatically and with neurology first, whether minor or severe. And so when you have a large academic center, just like the one we heard about in Spain, and also ours, with a lot of our resident physician colleagues, the importance of keeping them safe, keeping the staff safe becomes of paramount importance. And of course, not only keeping them safe, but preserving the health force. And so this is the principle of keeping our teams lean and effective. And prior to this, there was no framework in the stroke world for this in the context of emergency preparedness. And I can say that all of us feel that this pandemic has helped us get better. And I think that will be one of the silver linings after this is over. We initially started the protected code stroke with really two key steps. The initial one was screening. And this obviously means a lot less now that it is community transmitted. And so it's quite safe to assume that any code stroke presenting to any hospital should be treated as a protected code stroke. And in fact, we had a very low threshold for the past number of weeks that we've been instituting this across all of the sites to make those codes protected. But now, in fact, my colleagues have across the city met, and we have essentially designated all code strokes to be protected. And the word has gotten out. I'm sure my colleagues and myself have reached out to other community sites to tell them about this as well. But initially, it was screening the patient for infectious symptoms, travel, and neurologic symptoms that didn't provide a good history, things that suggested there may have been an alternate diagnosis, or if the patient was obtunded. And if any of those were the case, we would have ran that code stroke as a protected one. Transmission is obviously, there's a lot of data on this, and there's a bit of controversy, but essentially the large droplets greater than 5 microns are the most highly transmissible forms of this. And these are spread during things like coughing, even heavy breathing, in fact, and they can land within a 2-meter radius of the patient. There is some aerosolization of smaller particles, less than 5 microns, and especially during medical procedures called AGMPs. And those are more concerning. But for a code stroke, for patients that are not unstable and don't require AGMPs, probably still the #1 source of transmission is these larger droplets greater than 5 microns, and they contaminate the resuscitation environment in a code stroke. And so keeping us safe with proper PPE is critical, but also making sure that that is also done on the patient by placing a mask on the patient is key. So the donning and doffing, I mean, some of us who work in other environments, so like in critical care, as I do as well, we're more used to doing this, and now we had to have a whole bunch of folks, especially in neurology, get very comfortable with donning and doffing, and really like to do it as if our life depends on it, right? And it does. And so we, as part of the protected code stroke, we put in very clear guidelines that were congruent with infection prevention and control suggestions and also recommendations to put on PPE correctly, including sort of extended cuff gloves, a gown, a mask, a surgical mask, a face shield, and a hair bonnet. And if there were going to be any AGMPs, we in fact requested that our residents immediately come out of the room and allow other resuscitation colleagues like the emergency department and critical care to take care of the patient. There are some things that we cannot do anymore, things like bag valve mask ventilation, things like BiPAP. Those are all cannot be done in a, for example, definitely in a non-negative pressure room in the emergency department setting because they're highly aerosolizing. A key intervention that has emerged that we incorporated very early was the safety lead, which means a member of the team that's not part of the code stroke resuscitation ensures that every individual is putting on their PPE correctly and that there are no compromises to their equipment and that they're going to be donning and doffing precisely, including how they behave going through the hospital to the scanner and within the scanner, who remains donned and does not enter the control room, which really should be a sterile environment. So we paid meticulous attention to all of these things and implemented them. The doffing procedure is critical, and just a very small pro tip. You know, obviously the most soiled item comes off first, and that is the gloves, followed by the gown and then the face shield and so on. But it's safe to say to do hand hygiene between every step and ensure that things are coming away from your body during that procedure. That's an important point to keep in mind. So this was the second part of the code stroke, which protected code stroke. So essentially it talked about ensuring that proper infection control PPE measures are in place, and that if the patient is going to have aerosolization done to them, for example, if they require intubation, that would be augmented to airborne contact droplet. But what we put in quite early was to place a surgical mask on the patient. Many of the academic centers have now gone to placing a surgical mask on all patients as of about a day or two ago. And we were very early to recommend this and get it out in the world, because we knew that by placing a mask on the patient who may be heavily breathing or coughing or sneezing or just breathing normally, that the larger droplets, especially in the context of oropharyngeal weakness in the setting of stroke, could be transmitted to the teams nearby and the environment. And so that was, I think, a key intervention that we put out. The next thing was to bring into the realm of stroke a concept known as crisis resource management, which really comes from crew resource management or cockpit resource management in flight and aviation. And these principles, we kept it very simple: not to rush inside the room, to slow down and to put on PPE correctly. Because it is well known as in the special forces, in fact, that they say slow is smooth and smooth is fast. And we wanted to do that in the code stroke. We recognize that by meticulously keeping the environment safe and the team safe, that we would be then able to carry that code quickly and swiftly without having to pause, re-PPE individuals, worry about contamination, and etc. And of course, designation of the safety lead was another key intervention in these three-step procedures. We did at the time put a caveat about considering early intubation, but this has now also changed based on our clinical experience, and I'm not going to get into that for the purposes of this, but not every patient who's hypoxic needs to be intubated, and we've learned a great deal about that. These are the list of AGMPs, or aerosol generating medical procedures. The ones at the top are highly aerosol generating, which is why we've asked residents, and if you are physicians involved in these codes, and the patient is unstable, to immediately step out of the room and let the resuscitationist, who is the most experienced, manage the patient's airway and hemodynamics. Intubation and things like cardiopulmonary resuscitation and bag valve mask ventilation are highly aerosolized generating. And in the past, you know, a patient may have arrived that was intubated and then started to have recovery of their neurologic function. We very clearly said, do not extubate these patients, right? Because that is going to cause a massive amount of contamination in the resuscitation room. We used to do this in certain cases, but we no longer can do that. Non-invasive ventilation. The ones that I've highlighted are the ones that happen in stroke. So in stroke, we can get induction of sputum, if you will, in the procedures we do to a patient. So for example, insertion of an NG tube. So we've discouraged that if possible. Try to get away from inserting NG tubes acutely because of the coughing that it causes. And oral suctioning, again, a slight amount of debate. The current recommendation is not to include oral pharyngeal suctioning, but there is a fair amount of data out there from the microbiologists and so on, with a lot of experiments, and in fact, one of the co-discoverers of mRNA, who published a paper in the New England, that you know, any aerosolization from the oropharynx can cause smaller particles, and if you are near them and you don't have proper protection, those actually can transmit probably infection. We just don't know how much is enough, but certainly for, you know, airway procedures, it's quite sufficient. But these are the two to highlight in a stroke setting that are we would recommend deferring. So do not suction unless you have to, and definitely do not insert NG tubes unless you have to. And it has bearings on what happens post-resuscitation, for example, not post, but during the second phase, for example, into the neuroangiography suite. We also really hammered on the crisis resource management by these posters like this you'll see in many centers, but they were started at Sunnybrook and by my colleague Lowell Notario, who's the emergent educator. And we really wanted to keep the people in the room to a minimum. So one physician to examine the patient, one RN to help facilitate blood work and access, potentially another provider like an RT, but ideally the members who would stay inside the room would be just 3 with a mask on the patient, 2 people outside to help, whether it's a physician or another nurse or another team provider, with one person just meticulously not only observing the donning and doffing procedures, the donning certainly pre, but also how people behave inside the resuscitation room, and if they're contaminating themselves or the environment. You would be shocked how many people touch their face with gloves if they don't have a face shield on. They might touch their face or their visor with those masks. And so this was really, really key. And so we were very meticulous to suggest that. And for folks to leave the room if there's going to be any resuscitation, and leave that to the professionals doing it, like emergency department and critical care, just because of the high risk to the team. We developed this on March the 13th. We implemented it immediately following that weekend. This March the 13th happens to be a Friday. And we actually had our first code at Sunnybrook. The patient did not have stroke, but they were known COVID positive, and a code stroke was called for focal neurologic deficits in the context of a fall. We implemented academic half day, and getting the message out to all of our resident doctors who are at the front lines on March the 20th. And very quickly, both the other 2 academic hospitals have implemented their own version of this. And so kudos to all the University of Toronto folks and all the other folks who are implementing it, because we were very swift in coming up with this protocol and implementing it at other sites to keep the teams safe. And I'll just finish by saying that the situational awareness, which means that all providers in the room are paying attention to cues of safety, but also cues of patient deterioration. So for example, if a patient's going to deteriorate or looks like they're deteriorating, and a nurse is in there with a surgical mask and a face shield, we would ensure that another person immediately gets on with N95 and the appropriate things so that a switch can occur. And communication between inside and outside is constantly happening using, in fact, baby monitors. These principles are the crisis resource management principles, which we really are bringing into code stroke because it is a code. Cognitive load, and being conscious of the amount of cognitive load on providers during the resuscitation, and to minimize that, to use closed loops of communication. Please insert an IV and let me know when it's done. Are we ready to transfer? Is the patient stable? Are the orders entered? We have a checklist. All of those things are being done, much like takeoff and landing, before we go to the scanner to meticulously ensure safe passage and efficacy. We have role clarity, even where people stand is being addressed now, and communication, and we have put together a hot debriefing tool, which is after the resuscitation is done, we get together and do a quick debrief. And again, this comes out of the military environment and is used in other resuscitation, but we're bringing it into the code stroke environment, and hopefully are going to be writing about this shortly to talk about what went well, what didn't go well, what were there any equipment challenges, were there any other issues, and to do this in a non-confrontational, non-threatening, flat hierarchy environment. So just to finish off, we made a lot of changes to our stroke service. We virtualized all of our rounds, our morning rounds and our night and our handover rounds, in the afternoon are done virtually with residents spread across different rooms, and kudos to all the educational site directors at all the sites that freed up additional rooms so that residents could be far apart and using Zoom or other methodologies communicate about sign in and sign out rounds. We minimized repeat examinations during the code stroke as well. If a repeat assessment was not necessary, we were not doing it. If the patient looked like they had a very clear left MCA syndrome, we would facilitate the patient coming to the scanner, identifying that large vessel occlusion, and going to the angio suite without having to worry about if the NIH is necessarily 20 or 25. Obviously, that's different from our standard practice, but we thought to do this to keep people safe, especially in the early days when we were quite worried about, we didn't know a lot about how this was, how infectious it is and how we were protected. As you know, IPAC suggestions have changed quite a bit. We've also changed how daily work rounds occur on the ward as well, and minimize contact and repeat visits and things like that. And just the last thing is to be decisive in our management plans, to not play ping pong as far as what service the patient goes to, and to focus on expeditious patients coming in and going to discharge dispositions. And thankfully that is occurring. We're able to get people to rehab post-stroke, and that's been a very positive thing. So I just lastly want to put out this idea that we actually also, during this pandemic, it's unbelievable, in the last 2 weeks, we kind of brought all our work together. These are my colleagues who are resident physicians in our program, and we put together a podcast called Stroke FM, which I encourage you to listen to and subscribe to on all your favorite podcasts, where we actually talk about COVID and how to run a protected code stroke and how to modify our service in a bit more detail. So I think with that, I'll pause and take your questions.
Thank you, Houman. That was amazing, and I have had a chance to listen to your talk in other settings, and I thought this was very important to highlight to as many people as possible, as it is one of the most urgent needs during the pandemic. So thank you for sharing. I learned two things. I learned doffing as a word, and hot debrief. I learned some new terms today. I can imagine there's going to be many questions. We may not have time to get all of them. So do you mind putting up the website and the slide before one way that people can access a lot of these resources, the codestroke.net? Because I imagine there's going to be a flood of questions about that.
Yes, thank you. Yeah, you can access the website and the podcast for additional info.
So codestroke.net will have all the information, including publication and dissemination. Is that right?
That's correct. Yeah, there's a tab for COVID-19.
Okay, great. So questions. Are you doing low-dose CT chest for all your protected code strokes? Is this recommended?
I'm glad you asked that question. I happen to have an extra slide for it in anticipation. So initially, it was thought to be a good idea. And honestly, I have done it in one case, right? When a person was an inpatient, and it was an inpatient code stroke, and they had one single nasopharyngeal swab, which was negative, and they got worse clinically. And in that patient, and they had respiratory symptoms, I did bring them down for an inpatient code stroke and did a CT chest. The challenge is that early in the disease, and if you believe that patients can present with neurology and strokes due to various reasons, the early in the disease, the hit rate on CT chest is low, in fact. And so the current recommendation by the Canadian thoracic folks is not to do it. I know that some sites are doing it, and that's fine. The risk, the additional radiation from a code stroke perspective is not a tremendous amount for sort of a low dose CT of the chest because just the way the tissues react with different densities, you get good images. But unfortunately, it is not sensitive or specific enough to actually make a diagnosis. So I would say it should not be instituted as routine practice as part of a code stroke.
Okay, and we have another question related to the cath labs. What are the new challenges that you have identified in the cath lab for patients in need of endovascular thrombectomy? What has been your experience?
Very good question. In the past, we would not, bat an eye if the patient needed to be intubated on the table or have suctioning, etc. The challenge now is that we have to be a bit more better at forecasting who actually needs airway management before going to the neuroangiography suite. Now, with that said, we know that it's, if we can be avoided, that would be better for the patient, and that's kind of what the recommendation is as put out by Canadian Best Stroke Practices. The manuscript just recently was published. But if the code stroke period should be used as a way to not only treat and assess and treat the patient, but also to really pay attention to what the patient is doing. And so in our model, either the resident, senior, or senior resident is in the room, and the attending is either in the room or outside the room. We only have a few people. But one person really needs to keep looking at the patient and seeing if they're changing. And if they look like they're deteriorating, then it is a thought process to maybe they should be intubated before going to the angio suite, but ideal to avoid. I think the biggest challenge is if they require deep suctioning while they're flat, that would be a problem. So we do tend to put people flat sometimes before we have to take them anywhere just to see how they do. And I think that's legit. Put them flat and see if they're okay. And if they're okay for the scan and they're okay for a period after the scan as we get things ready, then they're probably going to be okay. But if there are changes that suggest they need to be intubated, that needs to happen. If you notice anesthesia, they're using one N95 per day. And it's being, sterilized and so on through each of the IPACs, through different protocols for conservation. But anybody at the head of the bed, because there is a risk of intubation and deep suctioning and things like that, I would recommend that I think the main anesthesiologist or anesthesia assistant and the interventionalist should probably, I think in my humble opinion, I'm not going to overstep, but it's just in my humble opinion, wear an N95. And that N95 can be reused as long as there's a surgical mask on top of the N95 and there's a face shield, then that N95 can be reused by putting it away for about 5 days. And the recommendation is it can be reused up to 5 times if it is not soiled or compromised, etc. And of course, it has to be a fit tested N95, and facial features such as beards and things must not be there. But I think for the people at the head of the bed in an angiography suite, for folks that are trying not to intubate these people if they don't need to, but if they were to deteriorate or require suctioning, then that is something to think about. In the future, obviously, post-COVID, many rooms are going to have negative pressure, right? This is a great time if the angio suite can go negative pressure, it's a great time to turn on that switch, because that's an additional way of protecting. And for folks that are stable, you can place a surgical mask on the patient with nasal prongs underneath and so on. That surgical mask on its own, it sounds like a barrier that's going to make their aspiration worse. But to be honest, kind of my experience, honestly, I don't think that it's the mask that's going to be the demise. So I would keep the mask on the patient as well during the angiography procedure with supplemental oxygen underneath. And there are non-rebreather masks with exhalation ports called HIOX and TAVISH masks that can be used as well for higher FiO2. So those are the things I would say. But my humble thought is the folks at the head of the bed, when a patient's having a situation done, should do that. Now, cardiologists are not necessarily doing that, but they're in a different, their patients can also code. So I don't know exactly what they're all doing, but I know anesthesia is wearing it, and I think the difference is if the interventionist has to stay in the room and be there holding the catheter wire. If you can't leave, if the patient's suddenly having to have an AGMP performed, then consider an N95, but go through proper reuse practices to minimize PPE usage, as I'm doing as well.
Okay, thank you, Houman. So just a couple of final comments, just to echo Head of Neurology at UHN. I think this is applicable for all the talks, to emphasize that all protocols and discussions we've had today should be adapted to every hospital's particular IPAC rules, or regionally and country by country to whatever institutional guidelines are required by site. And also, I'd like to echo what Head of Neurology at Sunnybrook has mentioned. We're very proud of your contribution and consideration for everyone's safety around the world. So thanks, Houman, very much. I did put up the two websites that you had there in the group chat, codestroke.net, stroke.fm. I've gone on them on my phone, and very easy to navigate, and I think all the information looks like it's captured there. So thank you very much, Houman. And at this point, I'm just again welcoming Dr. Montalban.